Good afternoon and welcome to today's webinar, Managing Change in the Lab, the People Side of Data Management Innovation. I am Lisa Dunet and I'll be your moderator for today's event. Today's webinar is part of the Thought Leadership Series supported by a generous grant from Siemens Healthineers. AACC has partnered with Siemens Healthineers to bring you this webinar series, which will continue throughout 2019. As a global leader in medical technology, Siemens Healthineers is a trusted partner focused on digitalizing healthcare with innovative data-driven IT and artificial intelligence solutions to derive insights and improve operations. This program is accredited for Accent Continuing Education credit. Please note that this webinar has been previously recorded and can be stopped or paused at any time. So again, we thank you for joining us in today's Siemens Healthineers Thought Leadership webinar, Managing Change in the Lab, the People Side of Data Management Innovation. Our speaker is Susan Dawson. Susan was recently promoted to the position of Laboratory Administrative Director at Swedish Covenant Hospital in Chicago, Illinois. Previously, she held the position of Clinical Laboratory Manager. She earned her Master's of Business Administration from North Park University and her bachelor's degree from Augustana College. She is also an ASCP certified medical technologist. Susan has presented on laboratory efficiency, automation, and auto verification in the U.S., Europe, and China. She has also co-authored abstracts and papers on laboratory efficiency, middleware implementation, and laboratory automation systems. For many years, she has worked with data management solutions, and in 2003, she implemented auto-validation for chemistry, hematology, and coagulation in her laboratory. In addition to using software solutions to improve laboratory quality and efficiency, her goal is to reduce work stress so that at the end of their shift, her staff has plenty of energy left to enjoy time with family, friends, hobbies, and other personal interests. Susan, you may now begin your presentation.
Thank you, Lisa. Hi, this is Susan Dawson, and I am the Laboratory Administrative Director at Swedish Covenant Hospital in Chicago. Today I'm going to talk about managing the change in the laboratory and how we handle the people side of innovation. Swedish Covenant Hospital is a community-based hospital located on the northwest side of Chicago. We have about 312 beds. We have about 12,000 admissions per year, 50,000 ER visits, almost 15,000 surgical, inpatient, and outpatient procedures per year, and just under 300,000 outpatient visits per year. We have an active open heart program, 2 birthing units, an inpatient and outpatient oncology program, and a community outreach program that's done in multiple languages for the communities that we serve. Swedish Covenant Hospital currently sits in one of the most culturally diverse zip codes in the United States. Within the laboratory, there are 65 FTEs in the technical area and in the clinical laboratory. We have 37% of those people are technical, with 63% being non-technical. 17.4 full-time equivalents handle chemistry, hematology, coagulation, and urinalysis on the day shift, plus the PM and night shift, and the PM and night shift staffing also includes coverage for blood bank and microbiology. We do 1.4 million tests per year, and we use a continuous flow process for 98% of the work that we do, meaning that as the work comes in, We place it on the instrumentation and process it immediately. We only batch or hold about 2% of all of our work. There have been a series of changes that we've made over the past 17 years in our laboratory. We started with automation in 2002, being one of the first hospitals in the city to bring in automation and an automated line, which also came with a middleware. In 2003, we used that middleware to set up auto-validation for chemistry and immunoassay testing. And in 2004, we added hematology and coagulation to that auto-validation menu. By 2006, we had expanded the testing menu that we were offering to include all infectious diseases. In 2007, and as part of a safety initiative, we implemented a patient ID system. So all the phlebotomists going to the floor have a handheld patient ID system that shows them everything they need to know about drawing blood from a particular patient, and they barcode at the bedside. In 2008, we started with computerized physician order entry, thus completing the full cycle of having a paperless system from time of order to the time when the physician sees the result. In 2015, we implemented MultiTOF in our microbiology area, bringing a chemistry mass spec into a previous area that had not had any instrumentation of that type before. In 2016, we implemented the second generation of our automation line, the first change that we had made to automation in 14 years. 2017 brought us automated urinalysis. 2018, we brought in new chemistry and immunoassay instrument platforms. And just early in 2019, we upgraded to the new operating system for our middleware. Change is the only constant in the laboratory, and change comes in all different forms, from new instruments to new software to new methods, and of course to new staff. The laboratory is so essential to the day-to-day operations of the hospital that during a change, we strive to make sure that there is no interruption in laboratory service, no critical downtime that affects patient care, and ideally, no one outside the laboratory should be able to tell that a change is taking place. In order to do this, lab supervisors, managers, and directors must set up a culture that accepts and welcomes change. To help make change successful, we make it a challenge, and we try to think of everything that could happen, the good and the bad. We do a considerable amount of pre-planning because we know that we need to have all of our bases covered for whatever we're doing, everything from the workload to the workflow and demands for customer service. We pull in key people to help make these decisions and help with this pre-planning step. We set up a proposed schedule. We involve the technicians in decision-making, especially about the timing of when changes take place during the scope of the day, also the use of the space, whether or not they will still be able to do their jobs if we're moving around in various areas where they have to get work done. And we always plan for the unexpected, not only from our side, but from the implementation side as well, leaving wiggle room for both the laboratory and for the vendor who's helping us make this change. Most importantly, we have to have a positive attitude throughout the whole process. When implementing and introducing change and new methods, whether it be instruments or software, it's always been helpful for us to provide correlations and comparisons between the current method and the new method that we're introducing. So we go through and we look at the daily functions. We discuss how they will stay the same, how they will change, what's new, what we hope to accomplish, and this applies to instrumentation changes and software changes. We draw a lot of comparisons for training, and we show improvements. We're very honest in the way we approach it because this is going to involve oftentimes rethinking how something is done, learning something new, or even in some situations might cause or require additional work to be done. We pay a lot of attention to the reactions of the technicians and listen to their comments. We actually encourage comments and suggestions, ideas, and try to implement those as much as possible. And this helps foster ownership and eventually pride in the success that we have. What we've found over time is that our success rate improves and our learning curve is much shorter when we use participative management style. And participative management is at all levels, everything from the phlebotomists to the technicians, the technologists, the management, the directors, and the pathologists. Everyone is involved in our processes. We do some design and implementation things to make changes work well, and we make sure that in this process, I, meaning the director or the manager, don't make the decisions in a bubble. We make decisions collectively, including the techs at all levels possible. Oftentimes, techs will actually volunteer to be involved in a change group or in a discussion group, and whatever is decided, we have to make it work for all the shifts. So when changes are discussed or suggested, we look at and say, will this work for PM shift or will this work for night shift? And we get together with those people and say, the people on the other shifts, and actually say, hey, is this going to work for you? Do you have an issue with this? Does your work flow this way? Will this create a headache, or will it be beneficial to what you're trying to do and the way your work flows in? And whatever we do, nothing is set in stone. If we find out that something doesn't work well, we change it. We ask, we communicate, and we listen. We do much more listening than we do talking in these stages, especially after we implement an initial change. We do a lot of communication with the staff, with the doctors, and with the nurses, and with the vendors. And this is this is communication that's both horizontal and vertical, both within and outside of the laboratory. With the communication within the staff, it's everything from putting large charts up on the walls to putting small notes on instruments or software, alerting people to changes or to ideas that people have had. Do you like this? Can you try this out? Things like that, just to gather information from all three shifts. We have staff huddles to exchange information. These often take place at change of shift, so we have information coming from the night shift to the day shift and from the day shift to the PM shift. We're very proactive in our communication with the doctors and with the nurses. There's a daily hospital safety huddle that takes place every morning with representatives from all departments within the hospital. And we make sure that we share at those meetings anything that might affect the entire hospital. We also send specific information to the emergency department and ICU because they are caring for the most critical of patients. We set up meetings with the vendor as well, using conference calls to document and track issues and resolutions. And then we also have the on-site team meetings. And this is where we exchange information, confirming plans and timelines. We discuss whether something can work on a given day at a given time, depending on what our customer requirements are at a given time, to make sure that there's no interference with us being able to provide excellent customer service. Through all our change processes, in the end, we want to do one thing to be true, and that is we want to have a standardized setup that works for all shifts, whether it's the bench area organization, the instrument maintenance, the reagent handling and workload, or the use of all the applicable capabilities in the data management that will relieve stress and increase quality. And standardization is probably one of the key factors in making things work long-term as well, because labs can tend to get very busy. And we always say when things kind of get hectic, when things get busy, go back to the basic standardization. Do what we do consistently. And this has been really, really helpful in any of the changes that we've implemented over the years. We face challenges when implementing change, and mainly it's because no two techs are alike. There's different learning styles that the techs have. Some of my techs are hands-on doers, while others like to read instructions and then try to do something. And when writing instructions, make sure everyone gets the same message. I can't tell you the number of times that I've written instructions that I thought were perfect, only to have the instructions tried out on someone who had never used the instrument and follow them for the first time and find out that the way I wrote it and the way it was interpreted were two entirely different things. And so we always try to make sure that any instructions that we write are proofread and proof-tried. And this has been really, really helpful, especially when you're passing information on to second and third shifts. The changes in the workforce and the approach that people of different ages and different skill sets have to work is very different in our laboratory. We have new graduates who approach things very differently than seasoned techs, and especially when it comes to computer skills and the comfort with computers, my new graduates and young techs are very computer savvy, much more so than some of my seasoned techs are. But we try to use the strengths of each of these two different groups to work for the good of us all. So my seasoned techs are very good at teaching instrumentation and methods and being able to help the newer technologists handle difficult situations and challenges as far as specimens go, where my younger techs are really good at working with some of the seasoned techs and saying, hey, this is how you can make this computer work better, or this is how this program might work better for you. And so it's a nice combination, and it's just fostering that exchange of information between the techs that has become very, very valuable. Explaining the what and the why is imperative. In order for the techs to determine a goal and decide the steps to reach it, they have to know what and why they're trying to do what is being asked of them. And we always have to be willing to try other options if our initial approach doesn't work or if poor feedback is received. We encourage people to speak up if they notice something is wrong or not working as expected or not working as planned. And all this serves to empower the staff to take ownership of what's being done. We have found that for some methods and instruments, a limit can be reached on how much can be done in terms of time and energy savings. But recently, we have looked at middleware products and computer software because we see a lot of potential opportunities to make lab life less stressful. Our most recent change involved moving to the next generation of our middleware, and two key components to the project that were done was that we were able to have some pre-work done offline, and this allowed us to not interfere with current operations, but to have these talks take place and ideas be shared amongst the techs in a non-stress situation. We were also able to make decisions on options that we wanted to see ahead of the implementation. So I would like to show you what we changed, and please keep in mind some of the keys that I have mentioned to success and see how that they were used. This was our home middleware screen for 17 years, and everyone was very used to this and very comfortable with it, and we changed it to this. And so immediately we implemented the correlation and comparison aspect of our change management. So nothing looked the same, and people had to find the functions and they had to find the information that they were used to seeing in a completely different format on this new format. Identifying samples to be processed went from clicking on a tube and clicking on words to looking at counters. And these counters were dynamic counters, and they suddenly discovered that they could make these counters do things for them. And so their minds started spinning and ideas started flowing because they wanted to try customizing and incorporating into these counters things that could help make their life easier. And they knew, the techs who were working the bench knew where they needed this help. So we have these counters in front of them that they could customize to meet their needs. And so just by clicking on one of the counters here at the bottom, they were able to bring specific specimens to the forefront. So the configuration themselves, to configure them, was very simple. And techs started looking at the options, started writing down their lists of things that they wanted. They had many ideas, many discussions over what was needed, what could be done, all for the good thinking, for the good of the patient, for the ability to report out results easier, quicker, faster, in a more controlled manner. And so they made these requests. We were able to set them up. And so when we got to the next step, we were able to take that same basic screen, click on one of these counters at the bottom, and it brought up a specific list of specimens. And these specimens all met a particular criteria associated with the counter. On these screens, they were therefore able to see things that they needed to see, a specimen number. They were able to see the priority of the specimen, the patient name, the collection date, physician ID, what status. And so from this list, then they got to turn around and just click on this and find a list of functions that they could do. They had options of what to do with specimens on that list. And from there, they were able to take it to perform a specific function. And this was all because they collectively decided what was the easiest and most functional way for our workflow and to meet the patient and our customer's need. And so with the empowered staff that we had, we ended up with very, very positive results in terms of what they were looking to do and how easily they were able to do it. The next project they wanted to look at was the QC monitoring and tracking. And this had always been something that had been tossed around, from being done at the instrument to being done in the middleware to being done at the LIS system. And so we sat down and gave the techs a list of options. Where do you want to do it? How do you want to do it? Do we need to change? What limitations do we currently have? What limitations do you want to get rid of? Is there a true opportunity to improve workflow, to make things easier? It got their minds spinning. And they wrote down their suggestions, and we turned around, and this is what we had before. We just had a simple icon. It wasn't very friendly. It took us a lot of clicks to get the information we needed. And what we found in the new software was we had QC alerts in full view. And then the tech said, okay, what can we do with these? And they were intrigued, and they took a look, and when they found out that they could just click on it, and suddenly they had clear visibility of tests that were had out of control QC. They could click on one of those tests and clearly see the test, the values that were coming from the instrumentation. It was very easy to track them. And this then generated a whole bunch of conversations that led to a completely different way for us to handle active QC in the system. And so this was one of those things that was totally unexpected on the part of the techs and on the part of management, but something that everyone jumped at and said, hey, let's do this. And it was quite an undertaking, but it was very well received, very well accepted, and it saved us a lot of time over the past few months. As mentioned, we've been doing auto-validation for quite a few years now, since actually 2003 and 2004. And we had a need to improve auto-validation functioning, if at all possible, for hematology, because theirs was one that was not quite as simple to set up and had a lot of various aspects to it that were requiring a number of different steps, as you'll see. So overall auto-validation, everyone had accepted as a total stress reliever. So people didn't have to worry, techs didn't have to worry about specimens that were being auto-validated, that passed through the criteria, that didn't get caught in any of the filters. Things were being auto-validated. That was great. But for hematology, things were a little bit more complicated. This was a previous screen that they had looked at, and you can see that there's quite a bit of information on these screens, and it could kind of, maybe some of the information could get lost. The screen did allow for both uploaded results that would be auto-validated and for the differential to be held in review, but then there were multiple other clicks and changes that they had to make. So in order to even get to the differential pad, in order to do a manual differential, they had to look at a couple of different screens, pulling up multiple results. They had to look to see what the errors were, which are, we have the red squares around here, so you can kind of see, okay, the review is there, the differential is being held in review, there's atypical and blast flags. At the top that they can see, at the top of the report, they can see that they have a slide that has been produced. But from there, they had to click on another button in order to bring up a cytogram that would give them additional information on the specimen, and click a couple more buttons even to get to the point where they could see a diff pad and then go ahead and perform a differential. But in the meantime, they lost the cytogram. So it was a multi-step process and something that definitely needed to be corrected or needed to be improved, and had a lot of opportunity there. So here is the new screen. They were able to separate the CBC from the differential. So here's the hemogram portion from the WBC through the platelet count on a single tab. And then they're able to see the previous results, the date, the time, normal ranges, whether or not any specimens, whether or not any results were held up by the instrument flags. They were also able to see the cytogram and the flags themselves all on the same screen at the same time. Huge difference for the techs, and they were thrilled that they were able to put the needed information all in a single view. If they clicked on the differential tab, they were able to bring up the differential. They didn't lose the flags, and they didn't lose the cytograms on the right-hand side of the screen. So all the information, again, that they needed was up front and center. And so immediate visibility and understanding of what they were doing. And then at the bottom, they could click on the diff pad button at the bottom and immediately bring up the diff pad. Again, this is a diff pad that they designed with the counters on certain keys on the keyboard. They could also do all their morphology flagging on the same screen, and they could still see that all-important cytogram, so they could check to make sure that everything that they were doing it matched all the way across. And so this was a huge change, and one that was very, very well accepted on the part of the techs, because it made life much, much simpler, and it was just total stress relief, less clicks, less moving around in the software. And so even the older techs really appreciated it, because it was a much more direct pathway to get to being able to do a differential on a particular specimen. So there are 6 things that are keys to success in the projects, in any of the projects that we have done here, and recently in the project of changing over software. We did a lot of pre-planning and got some input from everyone that we possibly could. We expected the unexpected, and we left a lot of wiggle room in terms of time for both the vendor and for the technologists to be able to adjust. We communicated from the top to the bottom, from the pathologist down to the tech working the bench, and from side to side, from shift to shift. And also we communicated outside of the department as well with the key stakeholders for customer service outside of the laboratory. We definitely use a participant management style, listening to the end users. The correlation and comparison between what we were doing before and what we were going to be moving to was so key to making this particular project work, because when you're changing software, people can get really, really nervous. And we were very honest with the techs, showed them step by step, used different styles to teach the techs. We listened really carefully. We changed things. They would come back to us and say, this isn't working. Can you do this? Can you do that? And so listening, knowing the techs, assessing their comfort with computer skills, we use this all to our advantage, oftentimes having a tech who is really good with computers sit down with someone who wasn't as good or wasn't as comfortable, and this was really helpful. And the vendor also helped in this process as well, and this is something that anybody who's going to implement any kind of change needs to rely on the abilities and the skill set of vendors as well, because they can come in and they can be very good at helping train and help your techs to get a better understanding of what is available to them and how they might be able to use any particular product. And when we empowered these people to say something and take pride in what they were doing, it really made for a very successful project all the way around. We have future projects on the horizon. We plan on utilizing the automation and the middleware to auto-run QC on the track. This has been something that the techs have actually wondered for a long time whether it could happen, and so we're going to look into this, actually storing QC in the refrigerated storage module that's on our track, and being able to pull it automatically at different times from the refrigerated storage, have it desealed, run, and returned to the storage unit. We're looking at using patient moving averages for hematology and for some of the chemistry assays. One of the possibilities is also connecting coagulation instrumentation to an automation line. These are all things that we haven't done, but as we have taken on certain projects, the techs come up with ideas on their own of things that they would like to do. But who knows? Something new might appear on the horizon in the rapidly changing landscape, and we will have to wait and see what that might be, but we always are looking for new things to do. We will continue to implement change and innovation, and we have found that changes are well accepted and highly successful when we keep our staff involved in providing input and accepting ownership using a participative management style. I'd like to thank you, and I appreciate the opportunity given to me by Siemens and by AACC for presenting our use of change management to all of you. Thanks.
Thank you, Susan, for sharing that excellent presentation with us. So we will now begin the pre-recorded Q&A session, which includes questions that were previously submitted. So Susan, the first question is, why did you decide to implement auto-verification within the middleware instead of the LIS?
That's a very good question, and I think it's going to be different depending on the current LIS and or middleware you have. But why we did it for our middleware is that middleware gave us more options. Middleware gave us more flexibility to be able to customize it the way we needed to customize the solution. So in terms of the hematology section, middleware allowed us to actually take our review criteria for whether or not a differential was going to be accepted, the automated differential was going to be accepted versus requiring a manual differential, actually put those review criteria, tuck it right into the middleware. And so that was something that the LIS just couldn't provide for us. The ability to use QC to hold up, failed QC to hold up patient results from being reported. This was also really key, something that we could stop results in the middleware after a failed QC from a particular instrument for a particular test. And so it allowed us to stop them up front and then actually rerun those tests as needed before the result ever went to the information system, so that was another key factor. Probably the third key factor was the ability to repeat testing or rerun testing either straight or on dilution, and being able to hold the result until we had the final result, and then just send a single result over to the LIS. And so by utilizing the capabilities of the middleware, it made things run much more smoothly, and we just had a single point of decision making, by using that middleware and not allowing any results to upload until they were completed. Because once they hit our LIS, they automatically are available to our docs, and so we want to make sure that we have all the work done and only the result going across to the LIS. There wouldn't be any future holding at that point. So those are some of the reasons why we decided to use middleware. Just the flexibility was so much better.
Thank you. The next question is, how were you able to standardize the changes that were made across all 3 shifts?
I mentioned in the presentation that standardization was one of the big things that we value, and it involved literally sitting down with each shift. I can remember in the early 2000s when we first started changing things, and we found that we would set up a particular workbench on the day shift and put tubes in one place and pipettes in one place and labels in a different place and have it all set up. And when we came in the following morning, everything was in a different place. And it was just like, okay, it was kind of one of these things where day shift would set it up one way, PM shift would set it up a second way, and night shift would set it up a third way. And it was very basic, but it just pointed out very clearly to everyone that, wait a second, we can't keep changing things on a shift-to-shift basis with something as simple as a bench setup. We need to get something that works for everyone. And so we brought in key stakeholders. We brought in the people from the night shift and said, what do you need and why? And did the same thing with the PM shift and the day shift. And when they all sat down together, they discovered that their needs weren't that different, but the demands or the way specimens flowed might have been slightly different, whereas one shift was more stat-oriented, the day shift was more routine work-oriented. And so just from that initial very simple thing of setting up a workstation, we discovered and got an appreciation for what every other shift was doing. And so we stopped looking at things as your work and my work from shift to shift and strictly looked at it as our work. And when we started looking at everything as our work, instead of requiring a particular shift to finish up everything and clean up everything before they left for the next shift, and started realizing that work can carry over from shift to shift and does on a routine basis, that set the stage and set the pattern for how we would implement things in the future. And so just from that basic understanding, the idea of standardizing for everybody's good just got ingrained in what we were doing. And so every time we try to make a change, we not only gather information from everyone, but figure out where is the best place for certain functions to be done, what's the best shift for certain functions, what is most helpful to other shifts. And so everyone is now looking collectively at it as our work. And so because it's ours and not his or hers or theirs or ours, it's always our work collectively together. And so that's how we've been able to standardize. And that appreciation goes a long way. And especially when things get really bad, having that set standard way of where things are going and going, what we call it, back to the basics of that standardized process has made things work much better and much smoother over the years, and has become a staple of what we do when we implement any changes.
The next question is, Did you have backup plan in case things didn't go well or just didn't work? And the second part is, how did you train all of the shifts?
Backup plans, absolutely. We work, part of the pre-planning effort that we put in revolves around determining backup plans. No matter how simple we think the change might be, we look to see what can go right and what can go wrong. And if something doesn't work right, just how are we going to handle that? Do we leave ourselves enough time? All that wiggle room dealing with backup plans if things don't go right. So we always make sure that we have a backup plan, even to the point when a particular project or a particular change is going to take place on a given shift or on a given day. We make sure that we have additional staffing available or the best possible staffing available, and we pre-plan ahead of time how we're going to handle, let's say, downtime or if things go wrong, to pre-plan ahead of time so that everyone knows what they're doing and everyone has their job. And so backup plans are integral part of the initial planning process. We don't dwell on them. We just make sure that they're in place. We hope we don't have to use them, but we always make sure, again, that they're there and ready to go. And everyone understands their role in the backup procedures so that we can continue to provide services even when things aren't going well in the lab that no one, again, outside the lab will know because we have things set up in such a way that the patient is always at the forefront of what we're doing, and the need to meet, the requirements of, the physicians down in the ED or up in the ICU or in surgery are always met. So that's always at the forefront. So backup plans, and as far as training other shifts, we've done it a number of different ways over the years. Sometimes the vendor has been extremely helpful in providing off-hours training, and that has been, we take advantage of that when we can and when it's applicable. Other times someone who can do the training will come in early, or we'll bring a couple people in early, one to relieve the person who's working the bench on the night shift, and a second person to help with training and to teach the night shift how to, whether it's an instrument or software or a new method or whatever, to teach them how to do it and to work with them in that way. We have crossover between day shift and PM shift, again, training people. Sometimes we'll pull someone from the PM shift who is going to be a key operator, and that person will be responsible for coming in on the day shift, learning the functions, learning how to do things, and then they'll be responsible for training on the PM shift. Sometimes we put people from day shift. We'll volunteer actually to work with someone on the PM shift and to work on the PM shift and show people how to do it. So there's a number of different, depending on the project, a number of different approaches that we have in order to help people adapt to the change. And in turn, what ends up happening is that sometimes the people who are doing the training come back and say to us, hey, wait a second, I saw the PM shift or the night shift do X, Y, Z, and I discovered that what they need some help in here, or we need to change something here, or they ask if this change could be made to help them with a particular problem or pinch point that they have. And so because the training, it just isn't one way, or the communication just isn't going in a single top-down method, but it's going back and forth, that, again, has helped with both the training and the implementation of changes. Lots of communication going on back and forth, and a lot of open reception to suggestions for solving problems and addressing the needs on the various shifts has been very, very helpful.
Well, thank you. That pretty much wraps up the question. So thank you, Susan, for sharing this valuable information on managing change in the clinical laboratory. I'd also like to thank all of you in the audience for listening to this Siemens Healthineers Thought Leadership webinar. To obtain your Accent Continuing Education credit, please refer back to the email you received with the link to this recording. And please note that this recording will be posted soon on the Thought Leadership Series webpage on AACC's website, where there is an archive of all the webinars in this series if you'd like to view others that you may have missed. And finally, be sure to mark your calendar for the next Thought Leadership webinar entitled Understanding and Overcoming the Challenges of Manual Inventory Management, which will be available on August 14th. If you do have any customer service related questions, please feel free to call our customer service line at 1-800-892-1400. So thank you again, and we hope you all have a wonderful rest of the day.